Hello everyone and welcome back to Desert Docs, a junior doctor's guide to Central Australia. This is a series all about the unique medicine and working life that comes with Alice Springs. Today I've got an episode all about our Aboriginal Liaison Officers who work so closely with us in the hospital and are an integral part to us working there. But before that, I would just like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Arrente people of Mantua. We recognise their custodianship and their continuing relationship with country, and that we work on their stolen lands. My name is Dr. Indi Barrow, and today I'll be talking to Sally, Donna and Christine. Hello everyone.
Hello.
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 So I would love you guys to introduce yourselves on the podcast today. So I'll go around in a circle. Donna, can you tell us a little bit about yourself?
Good day, everybody. Thank you for having me, Indi. My name is Donna Lemon. I'm a local Warrumungu and Arrente woman. My skin name is Nabuljari. I was born in Tennant Creek, raised in Alice Springs. I'm currently the Aboriginal Engagement Manager at the Alice Springs Hospital, and my role is to manage a team of 11 Aboriginal Liaison Officers that are quite diverse in their own language groups.
Mm-hmm. And Christine?
My name is Christine Ntaria Spencer, born and raised in Yuendumu, and been Aboriginal Liaison Officer for 15 years and really enjoy my job and helping our people understand the medical terminology.
And Sally?
What up, everyone? My name is Sally. I'm from Hermannsburg and I've been an ALO at the Alice Springs Hospital for 3 years, and the language I cover is Western Arrente and a little bit of Luritja as well.
Great. And our listeners can already hear that we've got so many different languages that we deal with our patients in Alice Springs Hospital. So Donna, you're a relatively new employee at Alice Springs Hospital from what I understand, but you've grown up in Alice Springs and born in Tennant Creek, as you said. What's your experience in your role in Alice Springs Hospital? What kind of things would we as doctors or nurses be talking to you about in the hospital?
So I come from a health promotion background, education and training, and so I'm really big on ensuring people have information that helps them to make really good decisions around their health, and well-informed decisions where they understand. I've only been employed with the Department of Health since July last year, so just over 12 months with the team, and we've created so much magic in that space, and we've done that simply because of really good, open, transparent communication. Aboriginal liaison officers have one of the hardest jobs in our town. It's to bridge that communication gap between our workforce, our family, and our patients and their families. And so it's really important that we support and nurture their growth and development in the area of their language group, and really give them the skills that they need to be confident in using their language skills in their roles. ALOs, we're not just translators. We are not a language service. We are a support system providing liaison advocacy and brokerage for patients and families across the hospital system.
And exactly how many languages do we have here in Central Australia, and are they all covered by our Aboriginal liaison officers?
Oh, look, there's about 900 Aboriginal languages in dialect at the moment. The language groups we currently have servicing across our hospital is Western Arrente, Central Arrente, Walpiri, Majida, Yawada, and that's it for now. But we are looking to recruit Pinjara, Warrumungu, Luritja, Pintabi across the system, because we've noticed that there's a big gap in those language groups.
Yeah. And we definitely need as much help as we can with that brokerage, with all of those different languages, for us to have the best communications we can with patients. Christine, what are the roles and responsibilities of an ALO? What does your daily work day look like?
We start 8 o'clock in the morning. We do our ward runs at 8:30 as a group. And if any of the languages are needed, like, for example, in surgical ward, we've got an interpreter there, an ALO that speaks the language. In surgical ward, because they like fasting and they need to go to theatre, but some of them don't know what they're going to theatre for. So we go in and ask them, and sometimes we get asked to do consent before they go to theatre when they use us. And yes, and we do family meetings and interpreting, do our ward rounds, go back and like talk to the other ALOs, debrief, and do it again.
And I think just to support what Christina said, it's really important that we get into the habit of using our ALOs whenever we need them, ideally from the start of an admission, because that way the ALO can follow the patient around for their duration of their stay and really look after their care coordination with the care teams.
And I understand that that's something that does need a lot of work, but because we do have quite a transient hospital staff that might not know the responsibilities and roles of ALOs. So it's an uphill battle to educate all of our new staff about how best to utilise ALOs. So again, thanks for coming on the podcast, and hope you can shed some light on how best we can incorporate ALOs with patients and with doctors. So Sally, when is it appropriate to involve an ALO outside of the ward round setting that Christine just talked about? When is it not appropriate, and what factors do we need to consider, like language, family, gender?
I believe, doctors need to always, like Donna said, always need to ask patients at the beginning if they need an ALO. I think that part there is very important, because sometimes we've been called up and there's been times where they've not asked, and the patient kind of just looks at us and then just kind of says, "Oh, look, I didn't ask for an ALO. What are they doing here?" And then that kind of just puts us in an awkward position. But it's always good to ask patients first if they need an ALO to avoid something like that from happening. And in some cases, culturally, male patients would definitely need male ALOs, and same for female patients, female ALO. In some cases, we do try and assist the opposite gender, but if it's only to do with things that don't involve talking about
anything below the belt.
That sounds better.
Especially if it pertains to their medical stuff being below the belt. That's really important for it to be gender specific.
Privacy is important.
We can't a female ALO cannot talk about things like that if it's a male patient.
What I'll just add in for the listeners is, even as a female doctor, I might need to rely on my male colleagues to talk about, again, things below the belt as well, because of those same reasons. So it's not confined to ALOs. It's experienced by staff all across the hospital as well, and important to be mindful of that before coming and working here at Alice Springs Hospital.
There might be, to your question, avoidance relationships as well. Culturally, we're not allowed to talk to certain people, and therefore, we're unable to assist maybe that particular patient with any kind of liaison or interpreting or anything. And that's when we'll probably get either you guys to get, I don't know, AIS or Aboriginal Interpreter Service, or maybe another ALO could try and help.
So usually if we have avoidance relationships in our team, we come together and we debrief, because we obviously don't decline work or liaison for anybody. We always want to make an opportunity to be out there and promoting our service, but also what people have access to pertaining to their health. But it's just a matter of the ALOs getting together, talking about the particular case of the patient, what their care coordination teams have said in huddle, and how do we support whoever the ALO is that has an avoidance relationship with these families and these patients, and then slot in where that ALO can then safely step aside, and we then take over that consult. There have been times where, as the ALO manager, I'm happy to step in for my team if there are avoidance relationships, because 9 times out of 10 I don't have those same avoidance relationship obligations, simply because of the way I was raised. And so I step in over the top of my ALOs and support them wherever they experience any difficulty, because if they're experiencing difficulty at the level of ALO, imagine how hard it's going to be to get that patient that we're supporting through the service safely and then discharged safely.
And so what kind of relationships are avoidance relationships, and what are those obligations?
So it's based on the kinship system and the obligations that we then sit under that kinship system based on our skin names and where we come from and our family connections and the things that we experience. And sometimes those avoidance relationships aren't known until people come together. So until they're in the same vicinity as each other, and then they realise that the connection is too close and we need to separate those people. But sometimes that's done as it happens. I'll give you an example of a current situation that we've experienced, and we had to actually come up with a plan to adapt. So we've employed an ALO in our ED department. There is an avoidance relationship with one of our existing employees, another Aboriginal staff member, and instead of making it a very uncomfortable space for them to work in, we just took the new ALO that we employed and put them on hours that are outside normal working hours. Therefore, there was no risk of them coming face to face in a hallway during work hours. But we had to pretty much come up with that plan at that time, and that's often what we as an ALO team have to do. We have to really think on our feet between ward rounds, between huddles, between debriefs, between our lunch breaks. We really need to ensure that we're constantly on for the whole of the hospital and including renal, Flynn Drive. Because it's not just the stuff we have to support at the hospital, it's happening in our own lives. So when we clock off at 4:21, we go home to our own lives, which are largely marred by trauma, sorry business. There's just lots of personal stuff that we also experience, that we experience inside the hospital as our work.
Like our work kind of follows us home.
It does.
Yeah, because we're dealing with our families,
Yeah.
people we know. Yeah.
And being so connected across the community as well.
Sorry business might be a good segue to explore, as well as the concept of taking on leave. What exactly is sorry business?
People mourning and grieving, usually
The loss. Yeah.
loss of a family member. Some of them might come back to the hospital and do a little cleanup, like with the leaves, like wiping the footprints of the person that's passed away. They might do something like that. So they can feel better coming back to the hospital to use it again.
And sorry business, there's no time frame. Like it can go on for months if it needs to. And it's a very important part of our culture. Like there are some patients, some people that may get sick and then end up in hospital, and then they get so worried because they're not there to be a part of sorry business, and so therefore they take their own leave or, leave against medical advice just to be a part of that sorry business because it's our cultural obligation.
And sorry business is lots of families getting together and mourning. Where does it happen? Does it happen on country? Is that why people take on leave?
Normally that's what happens,
Yeah.
Christine?
In the communities.
In the communities, yeah.
Where the person came from. They normally have sorry business back there. Then they wait for more families to come from other communities, and just goes on.
Months sometimes, yeah.
And if the deceased is brought to Alice Springs Hospital for whatever reason to prepare for funeral time and things like that, the ALOs are very supportive in taking families to the mortuary to say their last goodbyes. We've got really good support from our mortuary manager to be able to liaise with her in real time to get visits done as we need to or viewings done as we need to. But we sort of follow her guidance around that because of the process involved.
Okay. And bodies need to go back to country, don't they? Yeah.
They do, if that's the family's wishes, yes. So the Central Land Council have a repatriation service where Aboriginal people, if they want to be buried back in their country, the Land Council support with the financial means to be able to take the people back to their communities so that they can have their traditional sorry business and be buried on country.
Let's explore taking on leave. Sally was mentioning it earlier as something that we might see in other hospitals as discharging or leaving against medical advice. From my experience as a clinician, taking on leave is when someone's left without you becoming aware or before they've told you, there's no opportunity to sign that form. So you might come back to the bedside and the patient's left. And I understand that there's so many reasons that can happen, one of them being sorry business. What are some other reasons that people might take on leave?
It's mainly sorry business, family, like something happening with the family, like family obligations, send a link, because they only got 4 hours before they're told, and at the Centrelink they have to wait 4 hours and hours, and by the time they get back to the hospital, the bed's already given away because they don't understand the 4 hours. Yeah.
And we do have some good ones, that'll ring and say, I'm stuck at Centrelink.
Yeah.
Please don't take my bed off me, because they understand how hard it is to get back through the system through an admission.
Yeah, some people told because they're homesick, they don't want to be in hospital, or if maybe they're worried about maybe their kids or, someone else.
Yeah. And I guess too, because a lot of people who come into hospital tend to have a lot of support from families, when, especially community people, Aboriginal people from our communities, if they've come to town for doctors, and they might not have that support in town because it's been too onerous to bring other people in when are unable to financially. And so the ALO team really support these people that come into the hospital. If they decide to leave the hospital, we do encourage them to let us know where they're going, because while they might not want to tell our workforce for whatever reason, we do want them to keep communication open with us, because if they can see that we care about their health needs, they're more likely to share their story with us, but also return to our service. I mean, I've got my own personal story. I mean, the reason I wanted to work for Alice Springs Hospital was because both of my sons were born there, and, one of them was born quite sick, so constant back and forwards looking after, making sure that specialist appointments were attended and things like that, because we didn't have those services here. We had to rely on the doctors from Adelaide, and it was quite hard. But there's lots of system things, I think, across our hospital that we need to get better at doing in terms of administratively. When somebody presents to our ED, the demographics have to be asked. Do you identify? Are you Donna Lemon? Do you live at da-da-da-da-da? Those are getting back to basics, because I think we get so caught up in, all the other stuff that presents to our ED, we forget that the patient is in front of us, and that we have to ascertain from them and their mouth what their address is, where, if their contact details are the same. Otherwise, we're not able to get the information back to them about their care. Makes it very hard, and we tend to lose track of people because we're not up with their demographic stuff.
Yeah, yeah. Or next of kin.
Which is very different for Aboriginal people than it is for you and I.
Or the current phone number, because the last mobile phone got lost or stolen, or all those things. Okay.
You've always got to be mindful about the breaches in confidentiality too, because Aboriginal people, if they don't have phones but they've given us a number, that's the number we're going to ring, or we're going to send a text to. So if it's not the owner of the phone, there's that fine line that you could be sending sensitive information to the wrong person because that person has given you that number. So we just need to continually keep checking things are updated.
Yeah, and asking the patient what they want. Just going back to what we were talking about before, when reasons why people take on leave, I was made aware of one doctor who, as part of the first couple of questions, would say, how long do you want to stay in hospital for? Putting the patient back in control of what they want, because we might say, you need this, this, this and this, and the patient doesn't want any of that and has to go tomorrow as well to go out with the next car to Hermannsburg. So that's something I've learned as well. We have a lot of new staff coming to Alice Springs Hospital, doctors, nurses, radiographers, social workers, dietitians. All of these people may need an ALO. What are the key messages about communication for new workers coming to Alice Springs Hospital?
Educating them about what we do and the Indigenous patients, if that's what they want, because, they can come look for us or ask us anything.
My advice would be that they do some research on geographical location that they're going to embark on, because Mbantua is a very diverse, unique, spiritual part of our country, and people really have experienced culture shock when they get here. They need to do some research about where they're coming to, what services exist in our town, where you can go for fun, what's available on the weekend, which, you know, townships are in between, and do some research on, I guess, on the Northern Territory. It's really important, especially if you come from, you know, overseas. There is a real big chance that you will suffer a culture shock when you get here. And so do some research before you embark on this country, because it just makes our job a little easier and not having to educate everybody every day if we put the onus back on people that want to come and live and work here. Help us out. Nothing about us without us.
With what Donna was saying in regards to researching, yeah, definitely like research Central Australia. You know, there's a lot of different communities, remote communities outside of Alice Springs, and everyone's not all the same. Everyone speaks different languages, so don't just assume, you know, that we all speak the same language.
Yeah. When doctors walk into a patient's room and they expect the patient to look at them in the eye, that's not going to happen, because it's rude to an Aboriginal person to look them in the eye. And they might not look you in the eye, but they are listening. They're listening, but they're just not looking at you in the eye.
Body language is another one. Like, you know, when we walk into a patient room, we tend to sit next to them, not in front of them, not behind them, but next to them. Share that space with them. Know that it's safe for them to get up and walk out if that's what they want. But certainly don't stand in their way. Walk beside them.
And be mindful of the tone of voice you use. Yeah. Sometimes patients come across, I don't know, the sound of your voice as being, I don't know, maybe rude or not really caring in a sense.
Frustrated.
Yeah.
It's a big job.
Then that patient will close down, not talk to that nurse again.
Yeah, they won't engage.
Yeah.
And that's one thing I wanted to reiterate. Just because we are an Aboriginal liaison team, it doesn't mean people want our help. And they're very clear at telling us when they don't. So we're happy to support where we can, but we often get turned away as well from these families as well. So it's not all roses for our team either.
Yeah, it's a complicated and very necessary space. Another thing that I just will mention to listeners is on the topic of educating yourself, there's so many books, so many movies, if you know where to look. There's a bookshop in town called Red Kangaroo Books that is full of books about Central Australia, and also so many good movies and documentaries such as In My Blood It Runs, which was filmed in Alice Springs.
There's some really good resources too that have been created by the Warrumungu Foundation. Warrumungu Foundation is based in the Kimberley of Western Australia, and prior to the Northern Territory intervention about 12 years ago, Western Australia also went through their own intervention. And so we use a lot of the resources that they've created because the numbers are similar from the Northern Territory to Western Australia in terms of our incarceration rates, our percentage of people that have been missed in the school system. And so I encourage your listeners to go and have a look at the Warrumungu Foundation resources.
Yeah. Thank you, Donna, Sally and Christine, so much for coming on to Desert Docs. I think that everyone can benefit from learning a bit more about the cultural context in which we work in, and I hope this episode helps anyone coming to Central Australia.
The significant problems we face today cannot be resolved at the same level of thinking we were at when we created them. That was Albert Einstein that said that. We could take a leaf out of his book.
Thanks, everyone.
Kalamata.
Mucho.
Bye.
Desert Docs, a junior doctor's guide to Central Australia, is an anti-health media podcast produced with the help of ACCC Studio.